Thank you. I'm very glad for this chance to talk tonight about the opioid epidemic. And I would like to start by going way back to a medical teaching from the first physician who ever was a physician, Hippocrates, in 400 BC. He wrote a lot, he taught a lot, and one of his teachings that has come all the way down from that time is this: first, do no harm. It's a pretty short teaching, but it seems kind of odd. I mean, why would you even have to say that? If you're going to harm the patient, why would you even be there? But it turns out that sometimes, especially when a disease is very difficult, it's not as easy as you might think to tell how much your treatment is helping versus hurting. So really tonight, I just want to tell two medical stories of some times when I think that was harder than we expected. And the first story is about psychiatry. It comes from the 1940s. And back in the 1940s, we did not have any of the medical treatments that we have now for different psychiatric conditions. You might have had delirium, delusions, paranoia, aggressive behavior, but our main treatment really was to just lock you up in an asylum, and people still suffered terribly there. So people were very excited to hear that neurosurgery, a new field of medicine at the time, had a treatment that could improve many of the symptoms that people had. And that new treatment was the prefrontal lobotomy. This is an illustration from a lobotomy technique textbook by Dr. Walter Freeman, who was a big proponent of the procedure. It's fairly brutal, I guess, but it really shows what the procedure was. You strapped a patient to a gurney, you took an ice pick, you put it right there next to their eye on the medial side, you took a little hammer and you hammered it in. Maybe you give them a little anesthetic first. And you kind of scrambled it around, and the thought was that that would scramble up the connections that were malformed that were causing all of their symptoms. Here is a picture of Dr. Freeman. He is performing a lobotomy in that procedure. You gotta look close, but he's got his ice pick in one hand, he's got his mallet in the other hand. He is admired by some nurses, some assistants, and some local dignitaries as he shows you how to do this procedure. The lobotomy seemed very exciting at first. It won the Nobel Prize for Medicine in 1949. And it did reduce some of the symptoms that people had, but it almost always left patients worse off than they were before. You may have reduced their aggressive behavior, but you also made them forget why they ought to stand up from the couch and go to the bathroom before they had a bowel movement. They could not take care of even their basic needs. And as we realized that there was significant harm and very little benefit, it fell out of favor and fewer people did them. And in the end, even Dr. Freeman had his surgical privileges taken away and was forced to stop doing lobotomies. It took us about 10 years to realize that the harm was a lot more than the benefit for that procedure. So now I'd like to tell my second story, and this one goes back even a lot farther, 5,000 years back, to one of the first substances that ever was considered a medicinal substance, and I'd like to tell you how you make opium. People have been making opium since as long as we've even been writing, and here's how you make it. You grow some poppies, you wait till all the blossoms fall off, you'll have a bunch of seed pods on the top of the stalks there, then you walk down amongst the rows and you take a really sharp knife. And on this seed pod here, you'll see a little vertical cut. You make a cut like that in each seed pod, and you'll see a little milky sap kind of form where you made your cut, and it'll come down to the bottom and then drop off into your bucket or your basin, and you just wait for it to dry out. You take it home, you put it on your shelf, you can eat some later, make you feel good, or sell some to your neighbor. And as long as people have been using opium, we've kind of known some things about it. People really do like to use it, but it makes them very sleepy, sometimes so sleepy that they don't ever wake up. And after you've been using it for a while, it's really hard to stop using it, and people who use it don't function very well after a while. So now I'd like to show you a painting that I think shows all those things right in the painting. This is from the 1860s. It's called The Opium Eaters by a Russian painter. He just went to an opium den and painted what he saw. So just take a look, if you would please, at those gentlemen there. Do they look sleepy? Yeah, 4 of them are just zonked out. Do they look like they're functioning very well? They do not look like they're functioning very well. Over the centuries, wars were fought over opium between the people who were trying to eradicate it from their communities where it was destroying things and the people who still wanted to cultivate it and be the ones to sell it to somebody else. But by the 1800s, it was clear that people did awful on opium, but by now we had medical science, and medical science went looking for a cure to opium addiction, and it found one. It was morphine. Isolated in the early 1800s and soon used very widely for pain control, especially for people who were trying to get off their opium. It was used as a painkiller during much of the Civil War. You got thousands of soldiers addicted. But as the 1800s went on, we realized that morphine also made people really, really sleepy, and they sometimes died from an overdose, and after they were on it, they couldn't stop using it easily. So come to the end of the 1800s, medical science thought, we need a cure for morphine addiction, and they went searching, and once again, they found one. Morphine addiction was a terrible problem. Whoever found the solution to it would be a hero. So when they found this substance, they named it heroin, but nowadays we just pronounce it heroin. Here are some advertisements from heroin. If you look close, I don't know if you can read it, it says, got a cough? The problem has been solved by heroin from Smith's. The one over there on the right, Jarabe Bayer, the heroína, is a Spanish one. You can see if your little daughter has the cough or the croup, just give her a little syrup of heroin, leave the bottle on your table where your kids can admire it, and maybe sneak a little sip of it. You could just buy it in the mail, but in the early 1900s, it became apparent that heroin was no better. Who used it regularly was very sleepy and sometimes died of an overdose, and people, once they started using it, couldn't get off of it. But in the early 1900s, someone found a cure for heroin addiction. Who do you think it might have been? I'll give you a hint. It was not medical science this time. This time it was the United States Congress. They solved the problem with heroin addiction. They passed 3 different laws. In 1906, they passed one that said you cannot give heroin or opium for non-medicinal purposes. Came back in 1919 and said that didn't quite solve it. Here's another law. You can't write any of these medicines unless you write a prescription and track all your prescriptions. And that law, by the way, is why you have to have a prescription today when you get a medicine. Didn't quite solve it. Came back in 1924 and said, here's another law. By the way, we're going to tell you now that there is no such thing as medical use of heroin, so you can't write any prescriptions for heroin or for opium, and you can't import them. And so then all the people who had troubles with addiction to heroin went through very bad withdrawal. But after a while, their withdrawal got over, and the heroin addiction problem was largely solved. And after that, what happened was that 70 years went by, and we forgot that that thing had ever happened. So that gets us to the 1990s, and in the 1990s, we had another medical problem that we were focused on that was very difficult, and that was chronic pain. People who suffered for a long time from something where the pain wasn't going to get better, and our treatments really were not as good as we wanted to be able to help them. In 1996, the American Pain Society promulgated out the idea that pain should be the 5th vital sign, that people in all medical settings should check and treat pain as often as any other vital sign, usually using a 10-point scale, like you can see there. And also in 1996, Purdue Pharmaceuticals introduced a new pain medicine that would be much less addicting than morphine because it didn't wear off in between the doses. And it was OxyContin. This was accompanied by a large sales force, and that together with the teaching that we should be very careful to treat chronic pain, which as providers we did want to do, caused a huge increase in the prescription for OxyContin, and right at the same time a huge increase in the number of overdose deaths from opioids. We went from about 5,000 a year to 10 to 20 to 50, and now in recent years we're between 80 and 100,000 deaths every single year from opioid overdoses. It's been so awful for this time that we have put a name on it. That's our opioid epidemic. All of our healthcare organizations, our governmental organizations have tried to figure out how can we still help people with their pain without all of these overdose deaths. And I think the organization that has given the most guidelines is the CDC. Their most recent guideline is 90 pages long with more than 100 authors and dozens of recommendations. But in all those recommendations, I think the central one is the one where they say this is what you should do if you're about to start giving a patient with chronic pain, chronic opioids. And here's what their guideline says. It says, before starting opioid therapy for subacute or chronic pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy. So let's just think for a minute. If I'm here in my clinic, I've got a patient with chronic pain. It's really been bad. I've tried everything else I know for them, and I do want to help them, and I'm considering giving them opioids, but I want to follow these guidelines. What should I tell them about the known risks? Well, I would need to tell them about constipation, decreased mental function and grogginess, the possibility of withdrawal, suppression of your testosterone production could make your anxiety much worse, and in back of all that, the possibility of accidental overdose death. It is a daunting list of known risks. But their pain is really bad, and I really do want to help them. So what can I tell them about the realistic benefits? If their pain is, say, 8 out of 10, should I tell them, I think I can get that down to a 2 out of 10 with chronic opioids? maybe 6 out of 10 with chronic opioids. Well, fortunately, we have a different governmental organization whose job, when there is a bunch of different conflicting evidence, to synthesize it all down, and that is AHRQ. That's the Agency for Healthcare Research and Quality. And they twice have done this analysis for us. They did it in 2014 and 2022. They analyzed over 6,000 different publications about the use of opioids, and in all the questions they looked at, the very first one was this central one. How much pain relief do people with chronic pain get from chronic opioids? And when they looked through all those studies and summarized them down, they found that there were 0. There was not a single study that even addressed that question, not one. You could not turn to evidence to tell a person how much realistic benefit they could get. Since 2022, there has been one study that I think is important, so I want to show you that one. In this study, they just took people who came in with a very common pain problem, a very hurt neck or a hurt back, and they came into the emergency room and they said, hey, you want to come be in our study? We've got a study for pain. If you want to be in our study, come over here. We're going to randomize you. Half of you will give you oxycodone. Half of you will give you a placebo. We won't tell you which is which. We got these nice pills that look exactly the same. The people giving you the pills also won't know which one you're getting. Then all we're going to do is come back and ask what your pain is between these two treatments. So on this graph, the vertical axis there is just a pain scale. How much pain do you have? And all the study was to come ask the two groups at 2 weeks, 4 weeks, 6 weeks, how much pain they had. You're going to see a red line, and that line is going to be how much pain the people had who got the oxycodone. You'll see a blue line. That line is how much pain on average the people had who got nothing, no treatment. There was a placebo. And what they found was this. At every single time point, the people who got the oxycodone had more pain than the people who got nothing. At 2 weeks and 4 weeks and 6 weeks, the oxycodone caused you to be in more pain than getting nothing. That's really bad. But at the end of 6 weeks, we said, okay, well, that's the kind of the end of the treatment part of our study. So to just go to whatever primary care clinic you're going to, get whatever treatment you need for your pain, that's all fine. We're just going to come back and ask you at 3 months, 6 months, and 12 months how much pain you're in. And at 3 months, 6 months, and 12 months, who got the oxycodone was still in more pain than the people who got nothing. So we had not only made their pain worse, we had turned what was a short-term problem into a worsening of their pain for an entire year afterwards. So if I'm sitting with a patient and I want to tell them the realistic benefits of chronic opioids, really, I can't do that. Realistically, there is no study that shows benefit. There are studies that show it actively will make it worse. So, if we are giving millions of Americans a treatment that has no studies that show any benefit, on average makes their pain worse instead of better, and sometimes it accidentally kills them, then who are we? Who are we like? Who we are like is Dr. Walter Freeman, with an ice pick in one hand, hammering that up into the person's brain for no known benefit, known to make things worse, and sometimes killing the patient. And if we want to kind of compare these two treatments, let's just make a graph. Let's just say how bad was it to do lobotomies versus to give the chronic opioids. On this graph, there's two bars. There's a bar on the right that shows the number of deaths in the last 25 years, overdose deaths from chronic opioids. It's 570,000 Americans. Over 500,000 people have been killed because of dying, because of being put on opioids and having it spin out of control. On the left is a blue bar. It shows the number of people who died from lobotomies over the 10 years that they were done, but you cannot even see that bar. It is lost in the baseline. It is 2,500 is that number, but that's the comparison between the two of them. So in the end, there really is only one way that we can make the opioid epidemic better, that we can stop the opioid epidemic. And when I say we in this sentence, what I mean is clinicians who put patients with chronic pain on opioids, and I mean the governmental organizations that give them instructions and advice about how to give them those opioids. And the only way that we are ever going to stop the opioid epidemic is to stop giving people opioids. There are no studies that show that it helps. There are ample studies that show that it harms and sometimes kills people. It didn't help them when there were 2 opium dens in their little town. It did not help them when we got them stuck on morphine. It did not help them when we mailed them heroin in the mail. And it has not helped any of us in these last 25 years as we have given out these high doses and seen the destruction that it has caused. But in the end, just to say the same thing another way, maybe to take a step back and say it again, the only way that we can stop the opioid epidemic is to follow the advice of the first physician who ever was a physician, and to first do no harm. Thank you.